Yeah, it does look like we have everyone except for Jennifer at this point.
Oh, okay. That's great. Then actually, let's get started. So Rachel, I can see, well, first of all, welcome everyone. I hope everyone had a good summer. I guess it's been 2 months since we've met officially. So we had a little mini summer break, unless I'm getting my months mixed up. Maybe it was the month before last that we missed, but I would say summer is officially over, and I hope everyone's doing well. Rachel, I can see the first of the intro slides. If you can move that to, yeah. So I'm going to just get the boring part out of the way. The meeting is held virtually, hosted by the Utah Department of Health and Human Services and the Center for Medical Cannabis based in Salt Lake City, Utah. Thank you to our hosts. A public notice of this meeting was provided as required under Utah's open meeting laws, and it was posted on the Utah Public Notice website. In compliance with Utah's open meetings laws, this meeting is being recorded. A recording of this meeting will be posted to the Utah Public Notice website no later than 3 business days following the date of this meeting. Written minutes will also be prepared of this meeting. Approved minutes will be posted to the Utah Public Notice website no later than 3 business days after board approval. So if you could go to the next slide. Okay, and actually I'm going to do this out of order. Let's go to the next slide because I'm going to link my added purpose or my kind of explanation of our purpose to that. Do I need to read the names of the members for the official meeting? Does anyone know?
No, you just need to make sure, state that we do have a quorum. Okay. Obviously, and so that's important.
Okay, so we have the majority of our board members today, so we certainly have a quorum. Thank you to everyone for attending, and thank you to our staff. And let's see, is that the last slide? Okay, we welcome any visitors to our virtual meeting at this time. If you are logged into the meeting with a phone number and not a name, please state your name now so we can add your name to the meeting minutes. And I'm going to pause to make sure that people do give their names. I can't see all the faces, so I can't tell if there are just numbers, but please state your full name. And then in addition, we need you to state your affiliation and disclosures related to financial interests pursuant to the agenda item you would like to address. Just hopping back, if you have comments at the end of the meeting, you can use the raise your hand function appearing at the bottom right of the screen, and we will do our best to accommodate your request to make a comment. A conflict of interest may include, but is not limited to, any association or financial relationship with a grower, processor, manufacturer, marketer, or seller of hemp, cannabis, or cannabinoid, extended cannabinoid, or synthesized cannabinoid products, or an organization that lobbies for or on behalf of such. Comments will be limited to 2 minutes per person. So let's take a minute to do that. And I don't know, Rachel, you let me know if people are emailing you or texting you. Otherwise, I believe we're asking people to unmic and state their name and affiliations and disclosures.
Yes, that's correct. At the end of the meeting.
Okay.
And at this point, it doesn't look like there's anybody that's called in.
Okay. Okay, well, Rachel, can you just keep an eye on that if people do jump in to ensure that they give us all the information? Thank you. As a courtesy to everyone participating in this meeting, at this time, we would request that you place yourself on mute unless you are speaking to the group. Board motions and votes will be recorded in the minutes. Okay, now let's jump back to that. Yeah, actually, before we get to the agenda, I do want to state our purpose, and I am, unless people object, I'm going to read our kind of strategy or work strategy, which describes how we are fulfilling our purpose. Our purpose is to review the available research, literature, and assist the Utah Department of Health and Human Services and Center for Medical Cannabis in their efforts to provide useful treatment recommendations to qualified medical providers regarding the use of cannabis and cannabinoid products for treatment of certain medical conditions identified as qualifying medical conditions. And now is when I'm going to, Rachel, you probably don't have the strategy slides up, so I'm going to just pull those up here. So in that, to that end, I just want to remind us all of what the key components of a medical program are: knowledge and ethics, education for practitioners, and a continuous quality improvement and research arm. And translating that to us specifically in the realm of knowledge and ethics, we are working to create accessible and an updated list of available cannabinoid products that comports with current best evidence and consensus-based guidelines for efficacy and safety. Under the realm of education for practitioners, we are working to maintain an updated cannabinoid section of the UMA controlled substance curriculum. Thank you, Perry, for your work on that again. And we are seeking other ways to disseminate knowledge. And thank you to the department for helping to hire additional staff to support that effort. Finally, under continuous, which is misspelled on my slide, maybe it's corrected in the official slide, quality improvement and research. We are going to continue to establish and update guidelines and recommendations for practitioners and patients that are based on methodologically sound literature. Okay, now, Rachel, let's start the meat of the meeting. If you could pull up the agenda. Did everyone have a chance to look at the minutes? Does anyone have any comments on the minutes? Any corrections or edits?
I don't, so I move that we approve the minutes.
I second that.
Okay. All in favor, say aye or raise your hand.
Aye.
Aye.
Aye. And any opposed? Okay, the minutes are approved. Okay, so approval of the updated bylaws. I'm going to actually need, my brain needs a little jump start. Thank you for that. So Rachel sent this out a while ago, and Rich, jump in to help give any background that people might need. We did make some changes, as I recall. I actually can't, I'd have to go through my email notes to remember kind of the iterations. But does anyone have any comments or questions about this process? And we're going to need to update and then approve we're going to need to approve these. Yeah, go ahead, Perry.
Hey, this is Perry. Fine. If we go to Article 4, go back a little bit, and I think it's Section 1. and stop there. Go up a little bit. We're gonna get to the part where it talks about the products. Keep, if you would, Rachel, go to section 1 and now go back down the page to, I think it's, keep going. Keep one more. I think it's parentheses 4. Right.
There you go.
It's actually parentheses 5, where it says guidelines that the board develops in this section may not limit the availability of cannabis, cannabinoid products, or expanded cannabinoid products permitted under Title 4, Chapter 41A, etc. I think at least we should have some discussion and on the record, the fact that we have discussed and submitted recommendations with regards to certainly one product, and that was Delta 8 THC. We, of course, are not authorized to limit pursuant to the law, but I think that in terms of our bylaws, to expressly state that this section may not limit is to me is rhetorically not very helpful or useful. I think it would be far more useful in keeping with our mandate to say that the guideline that the board develops are explicitly intended to inform which products may be safe, which products may be effective, based upon best available evidence and science, and to make recommendations to the legislature and the Health and Human Services Department for possible revisions to Title 4, Chapter 41A, et cetera. I think that I would like to suggest that that would be an important procedural change in our bylaws, and that we make that as a voted amendment. And so, Katie, if you would be willing to entertain discussion about that, I'm very curious to hear how others might think about that.
Yeah, I think that's an important point that Perry's bringing up. I certainly
just pulled up the text of the law, and this looks like this is straight from the Utah Medical Cannabis Act, right? The words are just basically copy pasted from there, straight out of the statute.
That's right, Mike.
Yeah, so what I'm suggesting is that we don't just reiterate statute here. This is our bylaws. This is something that we create. Now we have to be consistent with statute, but our bylaws don't have to regurgitate statute. Otherwise, there's no really purpose for us. I think on our bylaws, we should state our operating procedures, and our operating procedures and our mandate is to inform and to educate and inform. And so I think altering that language to express that intent and that purpose would be important. Otherwise, the reason is, as I read through this, essentially we're just entertaining ourselves. We're giving ourselves a lot of work. We're spending a lot of effort. We're following the letter of the law in a sense, but we're not really following the intent of the law, which is to help the Department of Health and the Center for Medical Cannabis make really good informed decisions on behalf of both individual and public health.
Yeah, Perry, I didn't pick up on that when I read through these a couple of times, and when we were working on iteration. I think our bylaws end in that section end at number 4. I mean, they're called what our final product is guidelines. Guidelines are not laws, and guidelines are then applied by they're applied, and that's out of our hands. So I don't actually see the point of having number 5 at all. I don't know if we need to reword it. It's up to the others to make sure that our guidelines don't disrupt, the law. Our purpose is pretty clearly stated. We can go back to that original slide that Rachel put up and that describes our purpose to review literature and make recommendations based on methodologically sound science.
This is Rich. Rachel, could you just scroll up a little bit to in the bylaw document? I just wanted to read what those prior pieces of that were in the bylaw document. So if you go to 3,
Yeah, section 3, right.
Right. So naturally, there's some, what we're reading through right here is content that is also in the law. And, you bring up a good point. We don't just want to regurgitate exactly what's in the law. But Perry, I think one point you're trying to make is there's this need to share the guidelines and to ensure that providers and people in the public are aware of the guidelines and that they are able to access them easily and that they're easily understood and they're not, difficult to understand, right, Perry?
Yeah, and I think Katie's solution is actually that, she's a more incisive thinker, I think, than me on this point. I think we just eliminate that section because it really doesn't do anything except sort of, in a sense, in a couched way, say this Cannabis Research Review Board has no authority to do anything, which is actually true. We have no authority. So why do we shouldn't have to reiterate that in our bylaws? So I would accept Katie's revised thinking, which is just eliminate that last section because I think it's distractive. You read through all this and then it says, and by the way, you guys are basically impotent to do anything. So which is, it's a little bit offensive as to why are we spending our, the only thing we have in this life is our time to spend on this. So I would make a motion at this point that we just eliminate section 4. Parentheses 4 under section 1.
I want to, yes, I would love to hear if anyone wants to propose, anyone on the board wants to propose kind of some counterpoints or some thoughts that maybe would argue to keep that in, given that our purpose is to come up with guidelines. We have no authority to do anything other than that.
Well, I'll add my support, maybe not a counter argument, but, and to correct Perry, it's parentheses 5, not 4. 4 is different. And then under parentheses 3, and then parentheses D, it says any other guideline the board determines appropriate. That sort of leaves an open-ended method if we do want to add, because you said something about limiting. We have no authority to limit anything, but in the guidelines that we produce, a lot of the previous points suggest guidelines of appropriate use and treatment conditions that are appropriate. Nowhere does it really say where we should limit it or produce guidelines of what's not safe. But that section 3D does allow for that. We could give guidelines to say, well, this much is too much based on research.
Rachel, could you scroll down as we're speaking? Because I stand corrected, Matt's correct. It's parentheses 5. I was going by memory. And D is any other guideline. Go up a little bit so we can see D. There we go.
3D,
Yeah, it's a 3D. Yeah, there we go.
Thanks, Matt, for the correction.
Yeah. So Matt, you're saying that
I'm supporting it. 5 is superfluous. 3D gives us an open-ended way to say, look, this is what we found to be not appropriate or too much.
Yeah.
Our principal objective was to say what is appropriate use and appropriate conditions and appropriate dosing. But we've got to have some way to say, look, we found out what dose is too much and what's not safe, and 3D would allow for that. So
yeah. Which I mean, it's actually hard to come up with guidelines for medical practice that don't give you kind of the upper and the lower range. So that's a good point. But anyone else want to chime in on parentheses 5, the value of keeping that or removing that?
I don't know which way this argues for, but it seems to me that we could recommend whatever we want and it's up to them to decide. We could say that this product should not be available for treatment of condition X. And if someone interprets that as limiting the availability for the statute, that's up to them to say, well, the board recommended this, but we can't do that because the law says this, therefore we discard, or just, we will take your advice into account, but we won't do anything about it. And we wouldn't be, doesn't seem that we would be breaking any rules. It's just that it seems like those who are administrating all of this can't use what we say to then change what the law is. But it doesn't stop us from recommending whatever we feel the science supports. So I don't know if that argues for keeping it or not keeping it, but
Well, I would say that argues for getting rid of it. And that's exactly where I come at it, Mike. You know, and I think, Perry, it's what you're saying with a little more kind of explanation, is it's superfluous.
And
Anyone
I
else?
agree as, just representative of the Department of Health and Human Services. I think it's just redundant.
Let's exit. I move to someone make I don't know the official language. Does anyone want?
I made a motion, Katie,
Okay,
to eliminate
I'll second it.
parenthesis, and I make sure I say this correctly, Matt, parentheses 5 under that section.
and Matt, you second.
Yes.
Okay, done.
And just ask all in favor.
All in favor?
Aye.
I
Anyone opposed? Okay, good work. Anything else in that? I appreciate your careful reading of this, Perry, again.
I guess just a reminder that the area that we had originally updated for this meeting was down below under the public comment section, just getting the bylaws to more accurately reflect the actual process, because the original bylaws said that each person making a public comment needed to submit a form ahead of time, which was very difficult to actually enforce. And so we have updated the bylaws in an effort to make it easier for people to make their testimonies.
Yeah, thank you, Rachel. That's a significant kind of structural change in terms of these meetings. So everyone should be aware of that. And any questions about what Rachel just explained? Okay. So does someone want to move that we approve the bylaws with the amendment that we remove parentheses 5?
I'll make a motion. This is Dr. Norris.
Thank you, Dr. Norris. Any second?
I'll second.
Thank you, Matt. Okay. All in favor, aye. Say aye or raise hand. Aye. All opposed? Okay, great. Thank you. Okay, and Mike, thank you for agreeing to update us on your interactions with the Highway Safety Committee.
yeah, so I don't have too much to report back. I attended one of their meetings just to get a feel for who everyone is and what are they up to, and was very interesting to hear all the different people that they have contributing data and analyzing things, and down to some people here from the university who are looking at models of bike accidents versus on these streets and pedestrian accidents on these based on the qualities of the roadways, all very interesting stuff, and like troves of data that all these people are sharing with each other. Well, I guess the question And they invited me to do a presentation at their next meeting, which it turns out I cannot attend in November. And so it'll be in January where I get to talk with them. And I have some thoughts, but I guess I would kind of go back to that. I only kind of attended the meeting where that person came and presented, I think in April or something like that to this group. And I was only here for part of that. So I would welcome some comments from everyone else of what sort of things you would like me to present to them, and then see where we can go with things. I'll start with what I'm thinking is just one, maybe filling them in on my perspective as a toxicologist, emergency medicine, addiction, whatever my perspective is, all of those things combined of the influence of cannabis on driving, and what we think as far as what we know from other data sets as far as risk of harm with driving. And people may think that because it's a medical product that it's safe to use and it doesn't matter if they drive or not because it's medicine or whatever else. And what sort of additional information should we give to patients and recommenders beyond whatever label is currently on there about driving precautions, and what kind of data do we have to show what's going on. And then share some of what I know about cannabis and intoxication and measuring that and things like that. But I'd be happy to hear from the board about what sort of things you would like to see. And I guess what it comes down to is, what are we actually going to do together? I can talk people's ears off about cannabis intoxication and impairment, but I don't know what that would change or how we can make our two groups work together for the benefit of both.
Yeah, thank you, Mike. These are all, I actually think, Mike, it's worth introducing who you are and what you do. I don't know if everyone knows, Mike is at the College of Pharmacy and medical director at the Poison Control Center. But I think in you, Mike, we have a real resource. And I think I understand that you're just getting started, but I think where you kind of sit really gives us great information. So I would love it if you just could spend a minute describing who you are and what you do. And, maybe specifically comment on what you think your expertise could kind of add to our mission. I also just want to say before I forget, I believe that what Mike Moss is learning from Department of Safety as well as the Poison Control Center could make for a good email blast. I'm not sure the official name, but our efforts to educate providers and send out information. So maybe we could circle back after Mike introduces himself, but I think that's what you learn is important for us, but I think it's something that we could distill down and share with providers and public, if points come up that we feel that is relevant. So go ahead, Mike.
Yeah. So I wear a couple different hats and have had a convoluted path to where I am, probably like many of you. Right. I'm primarily trained in emergency medicine, but then did medical toxicology fellowship, and then added addiction medicine on top of everything kind of after the fact. I'm medical director of the Utah Poison Control Center that makes up about 75% of my time, which is managing overdoses and exposures from all sorts of drugs of abuse, chemicals, and things like that. Addiction medicine at the hospital, managing patients with withdrawal or substance use disorders and things like that. Medical toxicology is a pretty broad field. If anything exists in the world and can poison you, then I'm supposed to know about it. And then especially drugs of abuse and impairment and intoxication. And I even do some like medical legal work of, hey, this person was driving and they were drunk, or they had this drug, or they assaulted someone and they had this level of a substance in their body. What does that mean about their impairment or whatever else was going on, and interpreting those concentrations. And some of that, a subset of that is driving, and driving in cannabis is a very complicated topic. We think of alcohol as, quote, settled science of, if you have this much alcohol, then you're impaired. And it doesn't matter what's going on, you're impaired. The law says you have a DUI if you're over 0.05 in Utah. We don't have data like that for cannabis, unfortunately. We know that cannabis impairs people's driving. It's even worse if you combine cannabis and alcohol. Some of the big picture studies are pretty, are kind of tough of, does changing cannabis laws increase the number of people getting into accidents, and some of them say it gets better, and maybe it's because people are sitting at home smoking weed instead of going out to bars, right? But what happens is things get liberalized and people go out and use cannabis in public or in public spaces in other states where recreational is available, and how will all this impact it? I think from an individual standpoint, in a controlled like driving simulator, easy enough to show that cannabis causes impairment. There's also the question, what about chronic use? So the question gets quite complicated as to what actually happens, and it's not as clear cut as we think about alcohol necessarily. But certainly that's, right in my wheelhouse is what would the effects be on our population by increasing the amount of cannabis available in the community as far as influence on impairment and, road traffic accidents and fatalities. So that's kind of right up my alley of stuff is that. So that's my background plus a little bit of my opinion in general in cannabis. That certainly using cannabis and getting in a car will impair you, different from how alcohol impairs you in a car, but still to some degree, and not entirely clear which patients that is, though the same could be said for alcohol, right? We have patients who have substantial tolerance compared to naive drinkers who would have a different response to the same amount of alcohol, but we have a set limit that we've all agreed upon of what it is. So what to do with cannabis is still lots and lots of ongoing research as far as different levels and things, which I could get into at some point if anyone is interested. But the take for me is cannabis impairs people. How do we make sure that patients using medical cannabis are safe and that everyone's on the same page? And is there a way to monitor that with our other state partners?
Yeah, I mean, that's fantastic, Mike. And I really do think, I don't know, Rich, if this would be like a formal presentation that we could ask Mike to come up with, or maybe just some summary of what do we know right now about driving and cannabis that we would want our providers or prescribers to caution their patients about, specifically like language they could use when they are recommending cannabis, to have some kind of easy to repeat message for their patients. I think that would be a very helpful kind of educational piece that we could provide.
I
Katie,
agree.
Go
I
ahead,
have
Perry.
Rich, I've got a suggestion for you and Mike. Hope I'm not throwing you under some kind of bus. I'm hoping this actually be something you'd enjoy doing. But it seems to me that yes, we certainly do want to inform qualified and limited providers, but I think we really want to broaden that. And at this point, since we don't have a lot of science or exacting evidence to truly act on, I wonder if a first step might be, Rich, if you could get in touch with UMA and see if they might want to set up a sort of a Q&A with Mike, with Dr. Moss, sort of saying, what is the state of the art, the state of science? What would be good for the medical community to know about general use of cannabis and mixed with other things, the medical program in the state, et cetera. Just sort of a general informative, because I think if we jump to some kind of conclusions too quickly, it discredits us to a certain degree. But I think a discussion, opening up that discussion and knowing that there's this ongoing dialogue and process with the highway safety and with the Cannabis Research Review Board, the Center for Medical Cannabis, Department of Health, et cetera. And Mike, you seem to be the fulcrum here, and you seem to have as much knowledge. I think you're a resident expert, if you will, bridging all this. So Rich, what would you think about seeing if they would be willing to, for the UMA bulletin, to put out a sort of a discussion with Dr. Mike Moss about, and maybe also with someone, our friend from Highway Safety or whatever. And Mike, what would you think about doing that kind of interview if they were willing?
Yeah, no, that'd be fine. And I say for the record, I have put my own self on record in the adverse effects module I did as far as the cannabis provider review course. In that, I think I said don't drive within 6 hours of using cannabis. I think is what I committed to 4 years ago or whatever when we put that course together. And maybe there's some new information. So I have at least put myself on paper of coming down with a very one simple recommendation. Don't drive within 6 hours of using a cannabis product. And I could talk for an hour about all of that, but that would be the one line summary that I've at least already come up with. It's been a while since I revisited all of that data to see if I could nuance it anymore, but I think it'd be unlikely to be substantially different. And certainly I could do some question and answer, or have people submit some questions and write up a little article for one of the newsletters, or whatever format anyone would be interested in doing. I'd be happy to help.
Yeah, and just yesterday, I had a meeting with Michelle McComber over at Utah Medical Association, and she extended the invite to share information, and they can include that in their weekly emails that they send out, and also they've of course got the publication they do and other avenues and webinars, and I'll take advantage of that opportunity to make sure we can put something together, I'm sure, with UMA for sure on this topic.
Rich, do you want that to come as a motion or just as a discussion point that you'll follow up on? What's your druthers?
That can be just a discussion point.
Okay.
I'll let the board know. I can take action on that. I've got some meetings with Michelle McComber coming up here in the next few weeks, some follow-up meetings, and I can bring it up in those.
Great, thanks. And I've got another question, more technical question for you, Mike. There was some discussion that took place at the last legislative session where the discussion was around what are the sort of equivalents in terms of the literature at this point, looking at these formal driving simulation reaction test, cognitive, perceptual kinds of outcomes in terms of alcohol blood level equivalents and THC specifically equivalents in the bloodstream, and the numbers were provided and so forth, and I'm not sure to what use that was put in, but there is data about that. But it seems to me that we've got some, at least a little bit of initial science that creates some, in a sense, bioequivalency. We don't have that for other drugs. I mean, we certainly don't have that information for any other substances other than alcohol and perhaps THC. But where it seems we're really behind the curve in terms of being able to be helpful to or help inform law enforcement, and they've spoken about this at public meetings, is they've got breathalyzers where they can have somebody blow into the tube and they can say, okay, we can offer some discretion. We perhaps stopped somebody because they were weaving or appeared to be impaired, but they blew 0.04, so maybe something else is going on. But they blew 0.07 or 0.09, and that sort of ices the cake or whatever. But with all that as sort of lead in, where do you think we are, or how far away are we behind the curve in terms of creating some objective evidence for impairment that really does put that individual as well as the others using the roadways in harm's way, as we are with alcohol? Not that it stops all alcohol-related morbidity and mortality, but at least it gives some objective insight. What's your sort of projected view of where we might be going with all this?
Very, very short answer. It's complicated. Second part, I don't know that we'll ever get an answer that will be as satisfying as the answer we have for alcohol. Longer version, a lot of our field sobriety tests, blood alcohol, or the breathalyzers are all based around, it's all based around alcohol, right? You do your finger to nose, you're going to repeat some phrases, you're going to walk 1 foot in front of the other. All that is based on alcohol impairment. Cannabis impairment may not show up the same way. You may do okay on a field sobriety test and your impairment shows up in different ways that aren't detectable. So our whole framework for how law enforcement does this, and they have whole training programs called, drug recognition experts, where if you're suspecting that, the officer who's pulled someone over may call out one of their expert officers to come do this evaluation and, may get a legal blood draw, may do the breathalyzer, whatever else. And we don't have that for cannabis. Cannabis is also really complicated from a pharmacokinetic standpoint, as far as THC, active things of 11-hydroxy THC, and then inactive. And can you look at ratios of those things to see about how recent the cannabis use was? And what about if you eat an edible versus vape versus smoke? And that's going to change the profile of all of these. And some heavy users may have concentrations that are impairing for normal people, even if they haven't smoked or used cannabis for a week or two, at which point we clearly think they would not be impaired, even though they still have circulating levels of THC in their blood that could be impairing for someone who is a one-time or novice user. Some other states have gone ahead and set limits, right, of 5 nanograms per ml or things like that, or I think 2 in some other states where they just picked a number. And I say they just picked a number because it's not clear that that's as it's not as clear cut as alcohol. Someone may have picked a number and put that into their law in a given state, but it's not clear that that's as good. And then there is not an equivalent breath THC tester. Alcohol is somewhat volatile, and so it's easy to measure in breath. THC is not volatile in that same way to be so easily measured in breath. They're wondering, well, can you take a little cheek swab, saliva sample and come up with some sort of point of care test? So all that is active investigation, but then it also comes back to how good is that compared to blood? And what if I took and measured your blood and I measured 3 different metabolites and then come up with some calculated ratio of recency of use plus a newly designed field sobriety test specific for cannabis that can detect cannabis impairment that's equivalent to some amount in a driving simulator. So there's a lot of unanswered questions, and you can go look at cannabis and driving impairment and put that in PubMed, and you'll find a new paper every few months that pops up. I don't read all of those papers all of the time because it's not the main area that I'm dealing with on a daily basis, but I've read it since. But that's my understanding of where we're at with things. And I think the idea that we're just wait another year or two and we'll be at the same spot we are with alcohol is not the case. And also recognize with alcohol, it's taken us decades to get where we're at with 0.05, of even having a law and then having a federal limit, and all those changing from 0.1 to 0.08, and now Utah going to 0.05 and figuring out where all this is. And also to your point, we don't know this for oxycodone or for other medications. We have very small scale studies where they get some volunteers and put them in a driving simulator, and then some epidemiologic data and things like that. But alcohol is the only substance we really have great driving data on, in a grand, huge world of pharmaceuticals that could impair somebody. So that's my off the cuff answer, if that's satisfying for you.
Mike, just the fact that I understand you don't sit on the Department of Highway Safety board, although that sure would be nice, I think, from a public safety standpoint, because of what you're saying, that knowledge isn't out there in law enforcement realms or public safety realms. It's barely available within the scientific and medical community. You're one of the few. So I think, this ties in, Perry, to your initial kind of impetus to connect us to Department of Highway Safety. And I think, Mike, you are the fulcrum, as Perry said. And I think that, we need to emphasize that. We need to be aware of that in terms of our role as an advisory committee coming up with guidelines. These are the kinds of guidelines that can be helpful, not just for public and prescribers, but for other people who are invested in protecting public safety. So I think this is a boon that you're on our committee. I'm on the Controlled Substance Advisory Committee, and we met yesterday, and Amber Johnson from the Utah Poison Center attends that and gives kind of the reports. And that information might be helpful for you to share with the committee. She had said that she might connect with you. It was only yesterday that we met, but I think that would be helpful. Just, one of the things she brought up is, I'll get the numbers wrong, but something like 200 exposures to THC were documented, maybe a little bit more. And I want to say about half of them were between 13 and 19-year-olds, which I find profound. I mean, this is not the population that we were hoping would be using, and they're edibles for the most part. They're medical cannabis. So, and of those, not all of them were severe, but there were many severe and moderate kind of reactions. But I think that's important for us, and that I'm starting to see where we overlap with other kind of pieces of the pie, I guess. And I think, Mike, you sit at the intersection of a few of those places.
Yeah, I'd definitely be happy to share poison center data with you. Plenty of kids getting into edibles, plenty of teenagers and other novice users using too much and then getting super anxious and paranoid and panic attacks, and most often not having anything life-threatening, right? But certainly some burden on the healthcare system and on patients, and not a safe thing. So I got lots of data I'd be happy to share with the board that way, or whatever else, and whatever I can help Amber with on that side. We're kind of like two sides of the same coin over at the Poison Center. So I'll be at a conference with her all week. I'll chat with her about it.
Okay. So. And I know I want to be mindful of the time, but Rich, I would love, I'm going to take Mike's comment right there as he volunteered to present to us. I don't think it needs to be a formal presentation like when we were trying to come up with recommendations for qualifying conditions, but I do believe that we would benefit from some education by Mike in that realm. And Misty, it seems like you had a question or comment, so I don't want to leave that.
I just wanted to add Mike had asked for suggestions from us earlier about what to include in his talk. And I just wanted to, obviously you're going to talk about the risk of interactions with many of the intoxicants that you would typically think of, like alcohol and anxiolytics and pain medications, et cetera. But I would encourage you to also consider talking about some of the medications you might not think about, like your anticonvulsants, your anticoagulants, and even your ADHD drugs that are known to have really serious interactions with THC specifically.
Yeah, if we're going to stick to driving, that's going to get like, like no one will have done any of those studies, we're lucky to have alcohol and cannabis in combo, and I'll have to see, do I have an alcohol plus benzos, or even have a alcohol plus benzos plus cannabis study of all of those, and then getting into someone on Keppra or whatever else is what's going to happen. And then which part of this is the adverse effect side from just a patient being over sedated or having troubles or combining things with stimulants. From a driving perspective, it's going to be pretty darn tough to say anything else. I can certainly comment about just in general, combining all those things together.
And that's what
and I guess talking about the traffic people versus what I tell you guys about versus whatever else, or do you want poison center data? Do you want impairment data? Do you want drug interaction stuff? I could look at it from a lot of different ways.
Well, I actually, Misty, I think that's I would love to know that as well. But I think just in terms of the resource that we have in you, Mike, I think coming up with something that would help us be better informed in terms of the effects on driving is a priority. I mean, I don't think this has to be a belabored extended presentation, but I think if we can give Mike space on the agenda during these meetings, I don't know how, staying within our purpose.
And I think the law gives us a lot of that, of the safety and adverse effects is all all this will fall under that without any difficulty from my standpoint. And I'd be happy to pick like one of these topics per meeting or something to give you guys a little 10-minute thing on of today we'll do cannabis and driving, next time we'll do cannabis plus other prescription medications and risk and combination, or drug interactions and warfare, or whatever else you want to do.
I think that would be fantastic. And we, the poisonings and exposures could be in there, if possible, and what Misty's talking about, the interactions, so I really would like to see that. I know we need to wrap
more
up
than
this.
happy to.
Okay. So
Great.
maybe Rich, we can kind of discuss how to formalize that, Rich and Matt, and figure out how to get that on just a standard part of the agenda.
And Katie, if I might, and forgive me, I'm blanking on the name of the director of highway safety, the presentation that was given.
Yeah.
Forgive, well, with all apologies to her.
Carrie Silcox.
Yeah.
Silcox, yeah.
Yeah, Carrie Silcox. The data she presented was some that she had, but also some that came out of University of Utah database or study. And so, Mike, are you in touch with whoever that group is, or 'cause that might be
I don't know who that was. I know when I went to this meeting, I heard about some other people. There's some other department on lower campus of engineering or something like that we're doing some traffic stuff. So it may be someone else who's on campus, but not anyone that I had ever known or connected with before.
Yeah, I wonder. I mean, that might be a good group for you to connect with, just to see what data they're collecting, and might be a beneficial, even academically for you. I'm just thinking about where and how it's so difficult to get good data, and if somebody's already doing it, why reinvent the wheel? Or anyway, the other point about that is that it really did appear that she was reporting on fatalities, and that all of these individuals were then, there were tests for intoxicants of one sort or another, and that it seemed always the plurality seemed to be, no surprise, polypharmacy, but with cannabis, THC predominantly being very THC alcohol were very high on the list, and then a bunch of other things, obviously antidepressants and other things following. So they're collecting that data. I don't know, again, cause effect, we don't know. It's early on, so I don't want to overgeneralize. But I think that there is a link to be made now with the public outreach that we're going to come up on agenda item number 6, that Danielle Conlon is now in charge of. And so some of the information that you're providing, Mike, might be used for educational materials beyond just our group. So I think anything you do should be recorded and maybe transcribed, and that can be part of the public outreach program.
Yeah, Perry, that's exactly what I was getting at. That you made a comment though that we don't want to get ahead of ourselves with that, because we can, we want to make sure that we're making recommendations that are sound. But that's exactly what I was getting at, that when we are coming up with content for Danielle to transcribe into our email blast to providers, I believe this is some of the stuff that Mike brought up is essential content for those efforts, for those outreach efforts.
Absolutely. And I know some other states have done something similar, and we can learn from what they've done and also base it on some things that are maybe more current that Mike shares with us.
Yeah, and I mean, and they could, just, I know Danielle is kind of new and trying to work on, and we all are trying to figure out how to create that. But, if Mike is willing to do these kind of 10-minute-ish presentations to us, there's an outreach effort potentially that we could look at to see if some of that information that he shares with us could be useful for providers and patients. I think, Mike, my hope with your the relationship you're building with the Department of Safety is that they work on putting out messages to the public. They in terms of driving while impaired. And
Yeah, we
I,
have drunk driving billboards all over the place.
Exactly.
Why not don't token drive, right?
exactly. And they have the resources and the infrastructure, you know, and the authority that we don't, obviously, and that providers don't, and patients in the program don't. So hopefully that's one of the things they're aiming for. But Perry, in terms of your comment on number 6, that's exactly what I fully support that. And I think maybe Rich, you can help us
Yeah.
figure out how to manifest that
Sure.
in our meetings. So
Yeah,
And Rich-
yeah, we can working out the details on that.
And Rich, this sort of begs the question, and then I'll stop belaboring this, although it's such a rich and important public health area, it's maybe worth belaboring. You know, we've talked quite a bit over the last few years about linking the DOPL controlled substance database with a cannabis use database. And since most of these issues that we come up with that affect individual and public health are polypharmacy related, it doesn't seem sensible to disconnect the two as in separate universes, and a qualified or limited provider would not know, or a primary care or a tertiary physician like myself, outside of making extraordinary efforts to try and understand what's going on, be able to just simply counsel people to Mike's point about time and hours, and just sort of have at least just have a discussion about safety issues. So Rich, where are we with that as a matter of policy, given that it's controversial, given that there's always laws of unintended effects?
Right. So right now, the controlled substance database has live the ability for any prescriber that accesses the controlled substance database to go and verify if a patient of theirs has an active medical cannabis card. So there's actually some training. Danielle, did that update go out yesterday?
Yes, it did.
Great. So there was some training that we sent out to all of our stakeholders. There's I think 3,000 or 4,000 list of 3,000 or 4,000 emails that had information about how a provider can go in and actually check on that in the controlled substance database. And there's an icon they click on, and we give them instructions on how to go through that. And so that's available now. In the future, we will incorporate product information, but that is it's a complicated lift, just because of the fact that these products are just very different than your typical drugs that show up in the controlled substance database. And we don't want the information to be misunderstood when it appears in there. And also, it's just a big lift for our vendor and in our Department of Technology Services. But regardless, that is the phase 2, is to have that product information in there as well, and to also ensure that the product information is supplemented by information that helps the provider understand the product information.
yeah, just to be clear, Perry, maybe you knew this, and maybe others knew this, but what you're talking about allows a provider to check the CSD to determine whether their patient has a cannabis card.
Right.
That's it. It doesn't. So we check the database constantly in our OTP, and they have a little green leaf now. They've added a lot of it. If patients involved in the criminal justice system, hospitalized, deceased, but I can tell you, it's not. Yeah, I've been looking at it for over a year. I mean, that ability was there via fax and phone with someone in your department. You could, but it's not clinically useful. I can, more than half of the patients that have the recommendation don't go to the pharmacies in my,
Right. They could
my
still,
practice.
of course, go to the black market, or they could go out of state. Mhm.
Yeah, yeah. No, I have a distorted perspective. I'm just speaking anecdotally.
Sure.
I
But
just want to jump in real quick because we are at 10 o'clock, the top of the hour, and we've made it through half of our agenda. And I just want to make sure that there's enough time to get to the other agenda items as well as the public comment period. Just wanted to flag the time.
yeah, thank you, Rachel. But I think that there, you know, that it's been stuck at this stage for a while. I did get a sense yesterday, I think it's Jeff Henry that oversees the kind of
Yes.
technical side of the database, that he believes that this truly is happening. It not soon, but it now phase 2 actually is in the works, but I don't.
It
see-
is. And, you know, I want to emphasize, Katie, that prior to a month ago, there was no medical cannabis card information available in the controlled substance database. It wasn't there, period. And so just within the past month, we've been able to augment all this other information in the controlled substance database that's never been there before. It's now there. So yeah, we've lifted phase 1, but I understand it's not nearly what we want in the future, is having that product information and
Yeah,
information that helps the provider understand the product information, because so many, when they see it, they won't understand it. So we want to make
Yeah.
sure we don't just provide meaningless information, that it's actually understandable.
Yeah, yeah. Well, this is also fruitful discussion, but Rachel, I thank you for the nudge. Should we move to Lauren Heath? Is everyone okay? Can we wrap up that and let Lauren start? Okay, thank you, Lauren.
All right, good morning, thank you. Rachel, then you'll present my slides, or should I? It looks like you have them pulled up.
Yeah, just let me know when you want me to move to the next one.
Okay, great, thank you. So the purpose of this presentation is to briefly summarize results from a recent living systematic review on the effectiveness of cannabis for chronic pain, to provide an update on the evidence. We decided to focus on a summary of this review because of its high quality and its up-to-date results. The review was sponsored by the U.S. Agency for Healthcare Research and Quality and conducted by the Pacific Northwest Evidence-Based Practice Center. The review will be updated approximately quarterly, and please refer to their full report for details. Next slide, please. The original publication was peer-reviewed, and it was last updated in June 2022. In addition to the systematic review, when there was sufficient data to calculate a pooled effect, the investigators also performed random effects meta-analysis. They performed a robust literature search of multiple major bibliographic databases to identify randomized controlled trials or high-quality controlled observational studies with a duration of at least 4 weeks. Included studies had to evaluate cannabis or cannabinoids, which I'll refer to as CBPs or cannabinoid-based products, compared to either an active treatment, inactive treatment, or no treatment group. They classified the CBP intervention of studies into subgroups based on the type of CBP, such as whether it was a whole cannabis plant, plant extract, or a synthetic cannabinoid, and based on the THC to CBD ratio. The studied population had to be adults 18 years of age or older with chronic pain. Chronic pain included pain of various types, including people with cancer-related pain, as long as it was not for end-of-life care. Next slide, please. Jumping to their results, as of the June 2022 update, 29 studies have been included. Of these, 21 are randomized controlled trials, abbreviated RCTs, totaling about 1,900 randomized participants, and 8 are observational studies, including almost 14,000 participants. This slide summarizes some of the participant and studied CBP intervention characteristics. The most common CBP interventions studied in RCTs, comprising 16 of the 21 RCTs, were products containing THC, either as synthetic THC like dronabinol, or plant extracted 1:1 THC to CBD. Nearly all RCTs used a placebo comparator, and the majority of studies were for a relatively short duration of follow-up of between 4 to 12 weeks. Participants in the trial were primarily middle-aged and female with chronic neuropathic pain. The observational studies primarily studied participant-selected CBP compared to various comparators such as no cannabis or usual care. The maximal duration of follow-up was longer than for RCTs, ranging from 12 to 208 weeks. The population demographics were similar to RCTs, comprised of primarily middle-aged female participants with mixed musculoskeletal or neuropathic chronic pain. The review authors conducted a meta-analysis based on the RCTs, and overall, the body of evidence from the observational studies did not provide sufficient details for classifying CBP interventions, or the evidence was insufficient for reliable conclusions. So for this, the rest of this summary of the results, I'll focus on the meta-analysis of RCTs, which also aligns with the focus of the living systematic review conclusions. Next slide, please. Yeah, thank you. The next two slides summarize conclusions from the RCT evidence for a CBP compared to placebo for beneficial outcomes and selected safety outcomes organized by the type of product. Just to orient you to it, the left column of this table lists the type of CBP and chronic pain types studied in the RCTs. The middle column summarizes benefits and the strength of that evidence, abbreviated SOE. A plus sign indicates that the combined effect from the meta-analysis favors the CBP versus placebo, and a question mark indicates that the confidence interval for the effects suggested potential benefit or harm, but it was not statistically significant. And a line indicates that there was no effect. The right column summarizes selected safety outcomes from the review. An upwards arrow indicates an increased risk for the effect for CBP compared to placebo. And for reference, the review authors considered a small effect size on a 10-point pain intensity scale to be a mean difference of 0.5 to 1 point, and a moderate effect size to be a mean difference of between 1 to 2 points. So I'll summarize the results beginning with the top row of RCTs. That was the CBPs using a 1-to-1 approximately THC to CBD plant extract as an oral mucosal spray. Meta-analysis of these trials that were primarily among people with neuropathic pain demonstrated a small improvement in pain severity and function compared to placebo based on moderate strength of evidence. The oral mucosal spray may also improve pain response, which is defined as at least a 30% improvement in pain from baseline compared to placebo based on a low strength of evidence, but this effect was not statistically significant. Large increases in the risk of dizziness and sedation and moderate increases in the risk of nausea were observed for the oral mucosal spray compared to placebo. However, there was not a significant difference in the risk of serious adverse events compared to placebo. The second row summarizes studies of oral synthetic THC, such as dronabinol. The majority of these trials were also among participants with neuropathic pain. Meta-analysis of low-strength evidence showed that oral synthetic THC containing a high ratio of THC relative to CBD results in moderate improvements in pain severity and pain response. And there was no effect on function that was demonstrated based on 3 trials. Large increases in dizziness based on moderate strength of evidence and sedation based on low strength of evidence were observed for the oral synthetic THC products versus placebo. The oral synthetic THC products may also increase nausea and withdrawals due to adverse events compared to placebo, but this was not statistically significant. Next slide, please. The review authors also were able to perform some meta-analyses for oral high THC relative to CBD whole plant extract products, but were limited due to there only being 2 trials. There was insufficient evidence to reliably summarize the possible benefits. For safety outcomes, low strength of evidence for a large increase in withdrawals due to adverse effects and dizziness was found. The authors noted that there was also insufficient or no evidence to address efficacy or safety for low THC products, other cannabinoids, and whole plant cannabis. Also, there was insufficient evidence for non-placebo comparators. Next slide, please. It's also helpful to consider what gaps in evidence were identified by the review. This slide summarizes some of the areas highlighted by the authors as having limited or no evidence. There was minimal evidence for many chronic pain populations, such as low back pain, osteoarthritis, inflammatory arthritis, and fibromyalgia. Additionally, for many types of CBPs, including those that might be of interest to the medical cannabis population, there is no or limited evidence for benefits or harms. This includes whole plant cannabis, high THC to CBD cannabis extracts, low THC to CBD, and products rich in other cannabinoids. The evidence was also limited by the incomplete or inconsistently reported information for other outcomes that might be meaningful to patients and providers, such as measures of functionality, effects on opioid use, and long-term effects, which are especially pertinent to a treatment that might be used chronically. There's also limited information about CBPs versus active comparators. Next slide, please. I found 2 other recent systematic reviews of a similar focus to the one by McDonough et al. For comparison. Wang et al. 2021 included a similar population of adults with chronic cancer or non-cancer pain, similar cannabinoid interventions, except that they did not separate products by cannabinoid characteristics. Like McDonough et al., they also included RCTs with at least 1 month of follow-up. The efficacy results were similar to the living systematic review by McDonough et al. They additionally found improvements in sleep quality for oral cannabinoids versus placebo. In addition to the increased risk of safety events found in the living review, they also reported a small transient increase in the risk of cognitive impairment and impaired attention for CBPs versus placebo. They rated the overall evidence quality higher than McDonough et al., considering it to be moderate or high quality.
Lauren, I'm sorry to interrupt, and I must be missing something. In the Wang et al., is that we're lumping CBPs, we're lumping a lot of things in under CBPs and that. So this could be THC, it could be THC plus CBD, or is it CBD?
Yes, sorry, CBPs is a very broad term I use to refer to all of the products you just described. So it's similar to the ones included by McDonough et al., but they just didn't break it down.
Okay.
They did. So, and that's true for both of these other reviews I'm summarizing here. So finally, regarding the Wang et al., similar to the living review, they rated the evidence, they rated the evidence to be moderate to high quality, slightly higher quality than the McDonough et al. And the second recent systematic review and meta-analysis by Sainsbury et al. Included patients with chronic neuropathic pains with slightly narrower population and evaluated RCTs of cannabinoid products versus placebo of any duration. Sainsbury et al. Found similarly small reductions in pain intensity and higher proportion of patients with pain response with either the approximately 1-to-1 THC to CBD products or THC-based products. They included a few details on adverse events, and similar to McDonough et al., they rated the evidence as low to moderate quality. Next slide, please. Part of the purpose of summarizing this review was to evaluate whether updates to the board's current guidance for persistent pain may be warranted. Overall, I think that the board's current persistent pain document conclusion is similar to that of the recently published systematic reviews addressing various cannabinoid products for chronic pain. However, since the last version of the document, a handful of additional trials have been published. Additionally, the recent systematic reviews also address additional detail about the cannabinoids with the most evidence from randomized control trials and adverse events that are not addressed in the current persistent pain guidance document. Next slide, please. So in summary, the living systematic review found that cannabinoid-based products compared to placebo may result in small improvements in pain outcomes during short-term follow-up of 1 to less than 6 months. There's also evidence for possible moderate to large increases in dizziness, nausea, or sedation, especially for the THC-containing products. The evidence is most applicable to middle-aged people with moderate to severe neuropathic pain and for treatment with oral mucosal cannabis plant extracts containing equal parts THC and CBD or high THC oral products, particularly synthetic THC or THC analog only products. There was notably little evidence for many types of cannabis-based products, including other cannabinoids and whole plant cannabis. Long-term follow-up was also lacking, which would be particularly helpful to understand the potential benefits and risk of cannabinoid-based products in general and relative to other treatment options. The body of evidence should also be considered in terms of its limitations. Living systematic review authors graded the strength of evidence as low to moderate, where there is sufficient evidence to grade it. This shows some doubt about the measured effects, and the low strength evidence in particular denotes an effect that has major or many deficiencies and that could change with additional studies. At the discretion of the board, a few details from the McDonough et al. Living systematic review could be added to the persistent pain document if desired. Next slide, please. Here are my references, and thank you for listening, and let me know if you have any questions about the review or just general board discussion.
Rachel, could you go back one slide just to that last slide where Lauren proposes that there may be some additions? There we go, thanks. I need to be in this living review, Lauren, it looks like and that first example you gave, that we may want to consider revising the level of evidence that we came up with. Improved or decreased, lower strength or higher strength? I can't actually recall. It looks like most of this is lower moderate strength of evidence when there's some improvement to pain for some of these products. Is that what did we have, moderate or?
Yes, the overall conclusion is that you have is moderate, which could be totally reasonable. I just think anytime that we look at evidence to potentially update the topic, it's an opportunity for the board to consider whether that level of evidence should be revised. So I just wanted to point that out.
Yeah, thank you. Okay. So we kind of, in this realm, our comparison is moderate, and what they came with, where they arrived was low to moderate.
That's correct.
Lauren, great presentation. Thank you so much for this. This is really helpful.
I agree. Can I just say, Lauren, thank you so much for doing this. That's a lot of great information.
Yeah.
And I, for one, I like, based on my experience, I like when it talks about other pain outcomes, not just the pain, because it's been my experience that treating the actual pain is difficult. But when you mention sleep or function, those outcomes, I think, are tied to their pain, and their overall benefit people get seems to be more related to those peripheral or related outcomes than the pain itself. And so I'm really interested in pursuing more of those studies that look at those things.
Yeah, great point, Matt. I mean, when you look at, what we used to call chronic pain, I'm not sure if that's still how we like to describe it, but we know it's a syndrome of many debilitating symptoms, and sleep and mood and functionality are primary, so it's that question of not just how bad is your pain, but how are you coping with the pain?
Exactly.
Other comments? And Rachel, I think please keep us moving forward as you've been doing. Maybe give us an estimate, how much time do we have to kind of reflect and discuss this if we are being good time managers?
I was going to suggest about 15 minutes per section just to keep it moving. So, I mean, I would say now would be a good time to move on if you're feeling ready.
Any comments from anyone? Well, I'm going to take that as a no, not right now, but I,
Comment regarding what she had just spoken about. This is Zach Chase. I'm from Farmington. I'm a cannabis patient and advocate. I'm asking.
but,
If this
hi,
is
Zach. I'm glad you joined us today. Thank you.
My pleasure.
I believe we need to proceed with the board commenting, and if you could save your comment. And if I'm incorrect, Rich, please correct me, but Zach, can you hold
I'm
on to that?
When the comment section for public was, that's what I was asking.
Oh, yes, great. We will make sure that we leave a spot for you. And again, thank you for coming and.
Yeah, my pleasure. Before we finish, there's 29 participants right now. I wonder how many will stay and how long the comment sections will be and how quickly they'll be deduced. We ought not to let it keep happening the way it has. If you are servants for the people of Utah, let's remind us to make sure
I'm going to interrupt you and we're going to try to keep moving forward with the agenda. And then we can get to your comments and thank you again. Any comments from the board?
Thank you.
So Lauren, I believe you said this would be that the living system is updated quarterly.
Yeah, that's correct. It's due for an update sometime around now.
Okay, and will we be able to receive, I mean, will that be a continued effort of yours to share relevant updates?
Sure, I can do that. Check in and see if anything major has changed. Absolutely.
I believe I would like that. And I think in terms of the considerations for altering our recommendations, maybe we take that. Rich, I'm going to actually lean on you to see how we want to figure out if there are board members that feel based on Lauren's presentation, we should make adjustments. Not at this time in this meeting.
There could be, you know, a following of the recommendations of Lauren. She was suggesting that there be some updates, some new citations, I think, new citations of literature that she had shared, and that's a great idea. We want to make this updated according to new evidence that's out there, new studies that are being found. So.
Yeah. So yeah. I know we've got a lot with needing to do our annual report, but I think we need to kind of keep track of what Lauren's recommendations were, and maybe through email get people's thoughts on how, if, and when to revise.
Yeah, I can assist with that process. I can do that.
Thank you, Sarah.
I'm working with Lauren on this project.
Great.
Welcome.
Great.
Okay, so then let's move on to Danielle Conlon.
Okay, hello everyone. Thank you for giving me this opportunity to talk about the public health outreach efforts. So we have been working on extending outreach both to providers, but also the public health outreach to our patients about public health concerns and public health recommendations with using medical cannabis. We've recently published several handouts and made those available to the public. Those have been sent out to our medical providers via email. They were also highlighted in this month's monthly update that was sent out yesterday. And so I'll try to make this pretty quick just so we can keep things moving. But we have 4 that are highlighted today. All of the handouts we have coordinated with other organizations. For example, for the one that Rachel is highlighting right now, this is from the Gray Matters organization about teenage marijuana misuse. And so we are highlighting this to think about concerns about teenage misuse with cannabis and medical cannabis. Let's see, Rachel, if you wouldn't mind going to, yeah, perfect. That tab would be great. So we
before you move on, were you aware of the typo in the title of that last one?
Yes, yeah, I did see that. And I'll reach out to Gray Matters to let them know that there's the G instead of the J.
Thank you.
So So we also have one about cannabis use during pregnancy and breastfeeding. We coordinated with both Intermountain and the U for this content. This is all of our materials are evidence-based and based on public health guidelines from organizations such as the Academy of Gynecologists and obstetricians. Yeah, that's right, ACOG, as well as the CDC, FDA, and other large organizations providing evidence-based guidelines. And then Rachel, if you wouldn't mind going to 2 tabs over with health effects. Perfect. So we have this one just about general health effects that can occur in addition to the therapeutic benefits that can come from cannabis, where even if you're using cannabis as a therapeutic pharmacology, you know what I mean, like medicine for a treatment, there are also other health effects that can occur, such as the changes in coordination, movement, reaction times, mental health concerns, heart concerns, and lung concerns. All of this information was taken from the CDC, and we do highlight that when there are differences in teenage use versus adult use, and differences in smoking or vaping cannabis versus taking like a gummy or a tincture. And then Rachel, if you wouldn't mind going to the last tab with safe storage on the very right. Oh, perfect. And then we also have this information, which is a request that we've gotten just talking about using medical cannabis and storing it safely within the house to prevent it being accidentally used by others, and particularly children. And so this did use information from the CDC, other states' guidelines for safe storage, and information from both the national and Utah's poison control websites. Does anyone have any questions for me? Okay, excellent. If any questions come up, please don't hesitate to reach out. Thank you.
I was just gonna say, Danielle, these look great.
Oh, thank you.
Yeah, thank you, Danielle.
Rich and Danielle, could you just take a minute and describe beyond brochures and so on, is there a budgeting or a plan and a budget to go with it to do sort of statewide education and information, especially in non-urban parts of Utah? I mean, especially frontier Utah, sort of as to recapitulate sort of what was done with regard to safe and effective prescribing and safe storage of opioids and all that was done. Oh gosh, now it's been close to 20 years ago, 15, 20 years ago, but in order to respond to issues like that.
Yeah, I'll just, I can just briefly share some thoughts, and Danielle, you can add anything that I missed, but one thing Danielle is doing is developing a relationship with our communications office. And as she works on that through social media, there's definitely some very quick messages we can send regarding safe storage of medical cannabis and on teen use of cannabis, and these other messages that we feel are very important to communicate. We know that the most effective ways to share those messages is typically via social media. So that's one thing that Danielle is building on. Another item is we are getting time with the various professional associations more than we ever have. They're inviting us to come present at their conferences and things like that. We feel like that's a very targeted group, that if we target those groups, we can help share some of this important information that we have. And I think at this point, we don't have plans in our budget to do a major campaign where we're doing billboards, but I know Gray Matters is an organization that's nonprofit that does have some of that funding. And we've coordinated with them to do some of that more public type of thing that you'd see out on the radio or commercials or in public awareness campaigns.
That's great. And I would add, well, first of all, thank you. I think this is a really good development for the board. You know, as you can see, the board, you know, we need to spend time on things kind of closer to home, and the fact that you, Rich, and Danielle and the department is investing time in partnering with all of these other groups for the content as well as the dissemination is great, I think, and thank you for that new development. I would add Department of Highway Safety to, you know, a kind of a tool that you can use that can, based on the information that we learn over our time, you know, to be one of your partners that disseminates the information.
Absolutely.
So thank you for that. Should we move on? I do.
Yeah.
I think we should.
One quick or two quick questions. One is, where can these be found online? I know they were emailed out to the board, but is there a place that these live on the internet or the medical cannabis website or these various handouts?
Yeah.
Yes. So
Mike,
these
I'm
are
glad you brought that up.
Oh, sorry. Yes,
Go
so
ahead.
these are available under the resources tab of the website, and then under resource library, there is a section called education materials.
Yeah, I'm glad you brought that up, Mike, too. Thank you. I think it would be helpful if time allows that during these meetings, you know, this is when our time is really focused on this committee. If Danielle, you could just let us know, here's what's going out. You know, I don't think we need to belabor it, but it's helpful for us to know, as Mike is reminding us, it's helpful for us to know what everyone else knows.
Yeah,
definitely.
And Danielle, are you in touch with our outreach educator at the Poison Center, Sherry Pace, at all?
I have not been, but I will reach out to her. Thank you.
Yeah, I can send her your email, her email if you'd like. And we do these sorts of social media campaigns all the time of linking to things like this. So we'd be happy to help kind of be one more avenue of distribution.
That would be excellent. Thank you so much.
Yeah, thank you. Fantastic. Okay, let's move to Rich, your update.
Yeah, I can be brief. We've already provided some of the information that I planned on mentioning during this update. And so one of the items is, as a reminder, prescribers now can access information in the controlled substance database about a patient's medical cannabis card status. And so that's a new update. Also, the Utah Medical Cannabis System RFP, that was an evaluation of the patient's experience in Utah's medical cannabis program. We are in the process of reviewing the submissions on that RFP, and then we'll soon announce the winning bidder on that RFP. And we're excited about that. That's funded with some money from the general fund of the Utah legislature that they were able to appropriate to help do that RFP that requires an evaluation of the patient's experience in Utah's medical cannabis program. Also, we had a medical cannabis market analysis public input meeting that was held on September 1st. And the deadline for input regarding the market analysis is Friday, September 16th. And there are a number of factors that the Department of Health is considering in that analysis. And those were mentioned during that meeting and discussed during that meeting. And during the past month, we also presented at the Medical Cannabis Governance Structure Working Group meeting on August 8th. And at that meeting, Department of Health and Human Services, along with the Utah Department of Agriculture and Food, we presented our proposal for changes to the medical cannabis governance structure. And our proposal would move the responsibility over medical cannabis pharmacy regulation from DHHS to Department of Agriculture and Food. That's one of the most critical changes that we've recommended. And then we've also recommended the creation of a medical cannabis advisory board that would be comprised of a patient representative, a representative from one of the medical cannabis pharmacies, a representative from a cultivator licensee, a processor licensee, a QMP, and law enforcement, and also a public member. And we think that can be a good, healthy forum for receiving input from the public regarding Utah's medical cannabis program. And it'll be an opportunity also for the public to learn and get information about what the board items are, what the board is discussing, and also rules that we are writing. We'll get input from that board, and also regarding licensing of medical cannabis pharmacies, additional licenses. Those are topics that will all come before this advisory board, but it would be an advisory board. It wouldn't be making final decisions. It would be advisory to the Department of Health and Human Services and the Department of Agriculture and Food. So that is just what DHHS and UDAF have recommended, and lawmakers obviously have to take legislative action in order to do anything about that. We've got some administrative rules that we're going to file here in the next few days. Also, we'll be presenting to the Utah Home Care and Hospice Association on October 17th. Danielle Conlon recorded a pre-recorded presentation that they'll be sharing at that time. And it helps providers within that industry and space of home care and hospice learn more about medical cannabis and how they can choose to participate in the program if they choose to. How do they do it, and how can they get registered? And anyway, so that's an update from the Center for Medical Cannabis.
Great. Thank you, Rich. Any comments from the board on that? Okay, so let's, that's the final piece on our agenda. Everyone okay if we move to public comment with a couple of reminders? So we are asked to ensure that there's a public comment period. We're allowing, it's 10:39, so that will begin. Just a reminder to state your name, affiliation, and disclosures related to financial interests pursuant to the agenda item you would like to address. Keep in mind any conflict of interests that you may have, and share that with us. And we're going to limit comments to 2 minutes. And I need, Rachel, can you kind of call on people and then time and make sure that we limit to 2 minutes?
Yes, I can be timekeeper, and I will try and call on people as well, but I invite.
I can be timekeeper, so you can just call on people.
Okay, great.
Yeah.
Thank you. Okay.
Looks like we have Zach Newell's hand is raised, so go ahead and unmute.
Yeah, hi, my name is Zachary King. I'm a medical cannabis patient and also an advocate with Truce. I have struggled with chronic pain for 24 years since I had a paintball injury at age 13. That was the first time I actually utilized cannabis. It was the only thing that really helped with my pain, with my anxiety, with everything I've struggled with. And to hear all the talk about how dangerous cannabis is when I was on 6 different daily pharmaceuticals, and that was where I felt less like myself. I really hope that we can push for harm reduction strategies, and so that patients can afford their full 4 ounces of flower and their 20 grams of concentrate. I know that there are some individuals that choose to do so unsafely and to drive and do things that aren't smart, but the vast majority of patients are law-abiding citizens that deserve to have our full 4 ounces of flower and 20 grams at an affordable price. I wish that we could grow our own medicine, but I hope that we can focus more on organic farming and on what pesticides they use, what type of ingredients go into our vape cartridges, and just to understand what exactly we're consuming and to get to where the patients can be more involved and where we have more freedom. 10 years ago, my wife passed away due to an overdose of Ambien, and pharmaceuticals are far more dangerous than alcohol and cigarettes than cannabis ever will be. There's not even LD50 that's been established for cannabis. It's just so much safer. It's changed my life. I wish I could afford my full 4 ounces of flower and 20 grams of concentrate, but I struggle with chronic fatigue as a plumber. I'm trying to work through the day, and it's just so hard when I don't have the RSO that I need. I don't have the tinctures or the affordability. That's the biggest obstacle for us. And so if we could get to the point to where You focused on the way they cultivate our medicine, if they do it safely, if they do it to a way that's transparent, that patients can see it, that would be huge. And I yield my time. Thank you so much. Appreciate everything that everybody's done.
Thank you, Zach, for your comments, and very sorry for your loss. And I'm glad that it sounds like you're maybe getting some relief from your regimen. I do want to say we don't have control over kind of some of the things you touched on. Maybe after the meeting, Rachel or Rich could direct you to the body that is involved in kind of some of the growing and the amount allowed and those types of things. So I wish you luck with that, and thank you again for your comments. Let's go to the next person.
Christine, go ahead.
Hello, my name is Christine Stenquist. I'm with the organization Truth Together for Responsible Use in Cannabis Education. We're a patient advocacy group. You will see and hear a few of our patient advocates who are learning the process. So I beg the board's patience, as some of these patients are just advocating for themselves for the first time. I appreciate everything the board is doing to help further community education and safety on these topics. I just had a question, and I wanted to find out if you guys were engaging with some pro-cannabis institutions and professionals in the space.
Pro-cannabis organizations. I am not sure how that's defined. So I'm gonna
okay, I can clarify. So I have introduced to the board few cannabis physicians who have been dealing with the regulatory efforts and research involving cannabis. I hear repeatedly the board talking about working with our Utah Medical Association. I just want to remind this board that the Utah Medical Association was against medical cannabis. And so my urgent plea is that you guys engage with physicians and researchers across the country in states that have had programs in play, so they can offer their expertise as you guys bump up to some of the challenges that you guys have discussed in previous meetings.
Thank you for that clarification. So it sounds like the pro or the anti may be based on kind of the law, or the positions organizations have taken on the law. And that's helpful for me to understand. I do want to say, you know, maybe Matt, we have providers on this board who are qualified medical providers. Just so we have a lot of good information coming from the realm that is actually utilizing and recommending cannabis, and that's a real strength for our board in terms of.
With due respect, to be a QMP in our state is a 4-hour class that I could take. I'm asking if you guys are pulling on physicians like Dr. Ethan Russo, Bonnie Goldstein, Dr. Sulak. There are prominent names in the cannabis space who have been practicing cannabis medicine on patients that I think this board would gain a lot of insight from. That's what I'm asking.
Okay. Thank you for that question.
Okay, I guess that's not an answer that I'm looking for. I have done another email again to Rich and Dr. Perry Fine and several others that are in the department, reconnecting you with Dr. David Bierman, who can help you guys with the highway safety conversation. He was also one of the board directors of his health department in Santa Barbara. He's testified numerous times on highway safety. I just would encourage our board to really engage with these individuals. They're not trying to work against our legislation. They're trying to give you guys the best tools so you can write the best recommendations. I'll use my time.
Okay, I think you're doing the right thing, Christine, in terms of sending those names to the department to follow up on. I don't know, you mentioned a few names. I don't know if you know what our relationship is with them, to be honest, but I think your emails to Rich and Rachel should be fruitful in that. And so let's move to the next person.
Yeah, I'll follow up with you, Christine, about that, okay?
Thank you so much, Rich.
Yep.
If I can comment as well, this is Misty Smith from the board. Christine,
Yes, thank you.
I wanted to thank you for bringing up Dr. Russo. Dr. Russo is a very highly esteemed researcher in the cannabis field.
And a friend of many years.
Yes, and you know, he's a resource for us in research as well as the clinical practice. So and I want you to know that that's an ongoing communication resource for us. And as far as that goes, those lines of communication are always back and forth.
That is so reassuring. Thank you so much. Because Ethan really is invested into what happens in this state. We have been friends for many years, and he wants to see good practices throughout the country. So it was a favor for me to bring him. He wants to see good things happen for Utah.
And I personally have the highest respect for him. So thank you.
Thank you.
And he's cited in the documents that we published as well.
Yes.
Yeah, Katie, since my name was called out, I agree with Misty. You know, we have a very healthy respect for each other, going back decades. And now actually, Dr. Russo and myself got involved in trying to understand potential therapeutic benefits of cannabis and cannabinoids. Dr. Bierman is a name that you did bring up. We have, I think Rich does have his contact information. If he does have specific knowledge information regarding highway safety stuff, I think that would be an opportunity for cross collaboration. So Rich, if you can share that.
Yep.
I just don't want us to recoil from people just because maybe they're from California. Just because they're from California doesn't mean that they're bad, evil liberals.
I happen to be from Christine. I happen to be from California.
Okay,
sure if that helps or not.
Me too.
There are wonderful experts in this space, and I just want my state to know that there are people that want to see us succeed. And I, as a patient advocate, that's what I want for our patients in our community is a successful.
Let's move on.
Program.
So I'm seeing Jill Marriott. Go ahead. Jill, go ahead and unmute.
Yes, my name is Jill Marriott, and I am a patient, and I am a demographic of that study that was presented. I just want to say I totally disagree with the president. I mean, that might be what the study showed, but my own personal progress with the medical cannabis and pain relief, and comparing it talked about the dizziness and whatever it provides. Cannabis provides a whole lot less dizziness than those pain meds that I choose not to take. So I in listening to this whole presentation, which is the first time I have, I feel like you guys are trying to limit things, which is really discouraging to me because I'd much prefer to do this natural method than do the opioid route. And that's all I'd like to say. Thanks.
Apologies. Something happened with my connection. I don't know if others want to respond to that comment. I was not able to hear all of it.
Jill, I would just emphasize, this is Rich with this Department of Health and Human Services, that we are wanting to gather the literature out there, the evidence that is out there that represents scientific rigor and studies. And that's the purpose of the board, is to evaluate the quality of that research and to make recommendations based upon that. And so we aren't out there trying to find information that, or the board isn't out there trying to find information that is anti-cannabis. It's willing to take a look at anything that's out there that is evidence-based and scientifically done, that shares good, solid information that we believe the public would benefit from. So that's all.
Can I jump in a little bit, Rich? I also like to thank the comments from Zach and Christine and now Jill. I treat patients, and I've seen a lot of success with my patients, and it's been a really great experience for me and helping them. I want to just comment on Rich, your report about the Center for Medical Cannabis. I think this advisory board that you mentioned, I really hope that your proposal is accepted by moving some of the responsibility to Department of Ag, and then having an advisory board where we can have a greater opportunity for patients and advocates. Because that's what a struggle here is, we have limited time for these comments and advocacy. And I think that a separate advisory board would sort of divide the work, so to speak. Christine mentioned all these names and I'm not familiar with, but having another board to sort of divide this work and advance it, I think would be useful. So I just wanted to mention that, because I want to hear these patient experiences, and so that we can improve our effort in Utah.
Thank you, Matt, for that. Any other responses from the board or the department? Okay, let's move on to the next. We have what's our time, Rachel? How many more comments can we take?
We're at 10:53. I think we've got time for at least 2 more. We can try and squeeze in another. Let's go to Blake.
Hi, my name's Blake Smith. I am the CEO and Chief Science Officer for Zion Pharmaceuticals. And I just want to make a comment about the studies that are portrayed when you guys have these meetings. I have been told repeatedly that the only scientific data is stuff that is accepted by the FDA or FDA guided studies. And so,
which is bullshit.
I'm going to just interrupt. I think there's some unmuted. Thank you. Continue.
And so, I mean, I think what needs to be fine. It's not, you won't accept any scientific data. You'll accept only FDA approved data. I mean, I just completed a study literally with Loveless Biomedical, and they're a very well accepted military institution that does studies for every pharmaceutical company almost out there. And we have definitive bioavailability and mechanism of action data that has been completed within the last week. Yeah, but that's not from the FDA. That's from a company that does CRO, contract research organization for pharmaceutical companies. It's just that data is just as good as anything that I've seen presented in any of these meetings, and none of the data that's been presented has come from the FDA. And so I just say, get your standard. Like, what is it? Is an IRB approved? Is it a study that's peer reviewed? I mean, a lot of the references and the studies that were presented today were references that I had given to Rich previously. I mean, they literally were the exact same references. And so, but I was told that those references aren't scientifically rigorous. So I don't know. I just want consistency. Give me the definition, and it can't be FDA unless you guys only present FDA data. It's got to be one or the other.
Thank you for that comment. I think we get comments and feedback in that category often at these meetings. I'm going to defer to you, Rich, on a response if we need to.
Yeah. So I would just emphasize the statute sets the standard. We don't set the standard. And the standard that the statute sets is that it be either FDA approved or that it have the scientific rigor if it's out of the country. So we know there's some valuable studies that are done in other countries, and we've cited those and used those. But Blake, if you feel like there's one that you feel meets the same scientific rigor level, you're welcome to share that. We've invited you in the past to share those, and you're welcome to continue to do that. And I think you could agree that there are some studies that don't have FDA approval that would not be relevant and that are not based on solid methodology. And there are some, granted, that are based on solid methodology. So it's there's different types of studies out there of different quality, and you're welcome to share those that you feel are of the higher quality that you discussed.
Thanks, Rich. And I would agree with you. I would agree there are plenty of studies out there that do not show scientific rigor.
Yeah. Blake, I apologize for interrupting you. Let's get one more comment in.
All right, Zach Chase, go ahead.
Can you hear me okay?
Yeah.
Okay, thanks. Yeah, this is Zach Chase from Farmington. I'll thank you. I know you're all working really hard and we want to create a win-win here. I just wanted to, basically share.
Can you remind,
Yeah.
you did mention earlier, but can you remind us what affiliations you have?
So I am affiliated with Truce, and I'm an advocate because cannabis saved my life. It got me away from eating disorders, from puking after meals, to where cannabis just settled my stomach.
Great, thank you.
It got me, to reduce my alcohol consumption. It helped my mom reduce her pain pills, and she's older now and, at risk of an opioid overdose, since 45 to 65 old women are the highest overdose here in Utah. So we need to look at like what's going on, and that's not from cannabis. So yes, we need more positive studies. I agree with that. I agree that I love Lauren's details. She didn't say it's low to moderate. She actually said it's moderate to high if you looked at the Wang et al. Or whatever study. So let's make sure we're listening, subjectively to these patients as well as the data, because the patients are the data. And so, and these comments are these 2 minutes, quick. And I get that you have things to do, an agenda, because you're working together and you're making progress. However, we do get to have more time. What are your term limits? How much time do you get? Who are the people in charge of this organization right now? And how long will you be there? Will it be like some of these senators and people that are in there too long? What are the limits on you? And when do we get a chance to really speak what we're asking for and then have it be heard in your meetings? It hasn't been like that so far. We've attended enough in the past, and you guys are making progress and doing great things, but we need to address the things that the public are speaking to. And I don't think it's really being heard. Yes, some back channels, but let's make it a part of your public meeting if you really care about making cannabis better here in Utah, because it's obviously helping. It saved my life, got me off opioids, got me back to my kids where I can be present with them and play with them and know that dad's home and alive and with them and not dead, not a statistic. So we need to, kids' gray matter isn't developed or whatever, their prefrontal cortex. We can't have them all getting access to Colorado, whatever, edibles. So let's be smarter. Just like Zach King said, let's harm reduction the heck out of it. All that and say no to drugs never worked, because I was pressured to first drink alcohol. Luckily, I didn't get hooked to it. I served a mission for the church. I was an amazing missionary, whatever. I did my calling, and then ended up having more trauma, and then was triggered, pressured into other drugs again. One of them was heroin. I overdosed.
Zach, thanks for your comments. That's 2 minutes.
Yep.
Yeah, thank you. You've been through a lot. Let's, I don't know if we should wrap up, but I just want to
This
say
isn't about
that,
being through a lot. I want to interrupt Catherine because I don't seem to think that when you're hearing people's comments, I'm being heard, or any of them are really being heard. It's very selective. It's about, are we going to be listening to what the patient's stories are and how they can, get really saved and helped by this plant and do it in the right way. And you're in charge of that, but you get to listen to the patients. And I appreciate that. I yield my time.
Yeah, your
Rich,
time
I'm
is
going to
up.
turn it over to you. Thank you.
We need a motion for adjournment if that's where we're at.
Yeah.
I feel every public comment should be addressed in these meetings.
Well,
Everybody that's raised their hand should get their 2 minutes.
that is unfortunate that we're not able to
Well, you know
address
what?
the
My
agenda
wife
item
had terminal cancer, and she suffered and died for this program, and spent the last 2 years of her life fighting to get this program here to help other patients. I believe every patient, every advocate should get their 2 minutes.
Yeah, I think that is it's unfortunate that just time doesn't allow for us to take care of what's on the agenda as well as listen to everyone's comments. And I think we can, I honestly don't know what the solution is to that right now, but let's wrap up this
You
meeting.
speaking 45 minutes less than you did is the solution, and letting the patient speak at least half the time you did.
Zach, this is Rich Oborn with the Center for Medical Cannabis. You are welcome to contact us at any time and share your thoughts via email. You can reach out to our program. We can schedule a time to meet up. Also, at the next board meeting, you're welcome to raise your hand at the very beginning to ensure that you are on the docket. If you notice, there were hands raised at the beginning. We got to every single one of the hands that was raised at the very beginning. And I think we've been able to get some input regarding the board's business, and we thank you for that input. At any time, you're welcome to share your thoughts in writing. At the next meeting, there'll always be an opportunity for you to raise your hand, like we granted you the opportunity to do today to share your thoughts. You can also reach out to your lawmakers who are willing to listen and hear your thoughts. A lot of the issues that are coming up in comments are items that the board doesn't have the decision-making power over. They are able to, you are able to reach out to your lawmakers who have the authority to sponsor bills and to get support for specific legislation that I think would address some of the concerns that you're bringing up. Katie, you can go ahead and close.
Yeah, let's have a motion to close the meeting.
I'll make
And-
a motion to adjourn.
And do we
I would
need a second?
that.
Okay, thank you, Misty. All right, thanks, everyone. Take
Thank
care.
you.
Yep,
Thanks,
bye-bye.
guys.
This is a government of the people, by the